Greetings to everyone. I am myself Dr. Saurab Karki, presenting here a case of pericardial effusion in hypothyroidism in this webinar. My case is a case of 35-year-old male who presented with complaints of bilateral lower limb swelling for a week time. The swelling was insidious onset, which was gradually progressive in nature, and there were other associated features like facial puffiness, cold intolerance, fatigue, and hoarseness. On examination of the patient, he was fair. His vitals were notable for decreased pulse of 54 per minute. His blood pressure was normal with 110 per 60 mm of mercury. He was afebrile with normal respiration and saturation. On general examination, bilateral pitting edema was present and facial puffiness was noticeable. On systemic examination, nothing abnormalities were detected in cardiovascular system, respiratory system, nervous system, and gastrointestinal system. On investigations, his hemoglobin was 13.8 with a hematocrit of 41%. Leukocytes counts it was 6400 with 60% neutrophil and 35% lymphocytes. Platelet count was 325,000. As far as renal function is concerned, his urea and creatinine levels were within normal limits. Regarding liver function test, his serum bilirubin level was 0.7 mg per deciliter with a direct bilirubin of 0.1 mg per deciliter. His enzymes level were within normal limit, and so were the total serum protein and albumin level. Random blood sugar, it was 94 mg per deciliter, and for fasting lipid profile, it was significant for raised triglyceride level of 435 mg per deciliter. Other parameters like LDL, HDL, and total cholesterol were within normal limits. The significant and the concerning findings in this patient's investigation are in the thyroid function test, which revealed TSH level to be raised of around 150 with decreased both free T3 levels and T4 level of 0.8 and 0.3 respectively. Serum anti-TPO antibodies level was significantly raised of around 1412. His serum vitamin D level, free calcium level, and serum phosphorus level were within normal limits. ECG showed sinus bradycardia with low voltage QRS complex, while 2D echocardiography showed minimal pericardial effusion with normal ventricular function. Ultrasonography of neck was performed with thyroids, which were normal thyroid size, decreased echo texture, and increased vascularity of the glands. So summarizing the case, in a 35-year male presenting with bilateral lower limb swelling for a week time associated with facial puffiness, cold intolerance, fatigue, and hoarseness, with pulse rate of 54 per minute, with bilateral pitting edema and facial puffiness, and investigations showing significant for raised triglyceride levels, elevated TSH level, decreased T3, T4, and elevated serum anti-TPO antibodies, with ECG showing sinus bradycardia and low voltage QRS complexes, with 2D echocardiography showing minimal pericardial effusion. A diagnosis of hypothyroidism with minimal pericardial effusion was made. Following diagnosis of hypothyroidism, we decided to put the patient on tab thyroxine 200 mg once daily for 2 days, and we continued the patient on 100 mg once daily. For deranged lipid profile, we started the patient on fenofibrate 116 mg once daily. So we regularly monitor the patient, and the patient got symptomatically better in terms of his symptoms, like his pedal edema subsided, his hoarseness of voice which was present improved over a week time, and we repeated the TSH after 2 months, which was within normal limits. 2D echocardiography after 2 months shows no pericardial effusion. So this was our case and how we managed that has been presented. Pericardial effusion is a significant complication of hypothyroidism. Its prevalence can range from 3% in early stages and mild form of the disease to 80% in severe, long-standing and congenital cases. Talking about the pathogenesis of pericardial effusion in hypothyroidism, during hypothyroidism, it is found that there is increased capillary permeability of the blood vessels, which leads to efflux of albumin into the interstitial space. Thus, in the vascular space, there will be low oncotic pressure, leading to extravasation of fluid into the interstitial space. As for interstitial space, the lymphatic drainage is found to be dysfunctional. So, the protein, the albumin that has come into this space, gets trapped and pulls water along with it, leading to retention of fluids inside the pericardial cavity. Thus, there is development of pericardial effusion in hypothyroidism. These lines represent what has just been described. The pathogenesis of pericardial effusion is due to increased capillary permeability of the pericardial capillaries to albumin, and there is reduced lymphatic drainage of albumin in the pericardial cavity. The pericardial effusion thus develops insidiously. To diagnose pericardial effusion, different modalities of investigations can be used. As for X-ray, it usually shows enlarged cardiac silhouette with clear lung fields. This finding can have 38% of false positive rate and up to 30% of false negative rate. Up to 200 to 300 ml of fluids cause no significant changes, so the X-ray cannot be used to detect development of pericardial effusion in early stages. The next modality that can be used is ECG. ECG usually shows low voltage QRS complex where the total amplitude of QRS complex in each limb leads is 5 mm or less. It may or may not be present on chest lead where QRS amplitude of 10 mm or less in B1 to B6. If low voltage QRS with sinus tachycardia is seen, then we have to suspect cardiac tamponade. Electrical alternates where the QRS complex is alternatingly low and high in each beat with sinus tachycardia is a highly specific sign for pericardial effusion. However, the finding of low voltage QRS is not specific for pericardial effusion in terms of hypothyroidism. It can occur in hypothyroidism in patients presenting with advanced age or with thyroid hormone deficiency itself can present with low voltage QRS. The ECG in the figure shows low voltage QRS complex in both limb leads and the chest leads. Echocardiography is the next modality that can be used, which is very important for detecting pericardial effusion. It can detect pericardial effusion up to 30% of the patients. Regarding the role, it has a role in detection of presence of any fluids, quantification of the amount of fluid present, and it can also assess the hemodynamic impact by the compressing fluid in the pericardial cavity towards the heart. Pericardial fluid appears as equiescent space between the pericardium and endocardium as shown in the figure. The figure is a 2D echocardiography of a subcostal view showing massive pericardial effusion and right ventricular diastolic collapse. The problem with echocardiography is during early stages of pericardial effusion. In early stages, there are minimal fluid and the pericardial cavity itself contains around 25 to 50 ml of physiologic fluid. So, the 2D echocardiography cannot distinguish between the type of fluid, thus accounting for its disadvantages. Pericardial effusion can be reversed over time with thyroid hormone replacement. There are potential complications as well as the life-threatening complications that can develop following pericardial effusion like cardiac tamponade and hemodynamic instability. It's crucial that we assess these complications at early stage and manage them so that the complications that arise due to these processes can be prevented. So, in a nutshell, hypothyroidism is an uncommon cause of pericardial effusion. If unnoticed, the pericardial effusion can be fatal. With early cardiac assessment and adequate thyroid hormone replacement therapy, pericardial effusion in the setting of hypothyroidism can be reversible. These are my friends and my seniors who have been continuously providing their efforts in publishing this manuscript as well as preparing this presentation for presentation in this global platform. These are the references from where I prepare my presentation as well as my manuscript. Thank you. Any questions and queries are highly welcome.